To understand, focus, and practice things, we need good practices, learnings of others, which guides us to follow suit. Hence now, we present the good practices in midwifery from other state, and we have two prominent speakers who have joined us virtually. The first speaker would be Dr. POONAM Verma SHIVKUMAR. She is the Director, Professor OBGY and Medical Superintendent of KASTURABA Hospital, Mgims, Wardha, Sevagram. And she is a core committee member of PPH Working Group, International Federation of Gynecology and Obstetrics, and President Sevagram Wardha, OBGY Society. She is the principal investigator of e-partography, stillbirths and preventable birth defect project, WHO CRO and others. She is also the technical advisory group member of International Clinical Epidemiological Network and India Clinical Epidemiological Network, Biomedical Research in HIV and ICMR. She is also one of the resource person and expert for Government of India and Government of Maharastra for national guidelines development in maternal health. She is also the nodal officer on facility-based MDR committee, and she is also the contributor to Government of India Toolkit and Clinical Skills Lab Manual. She is also the recipient of Award for Management of Anemia and others from Government of Maharashtra. She has 78 articles and 8 chapters in international and national journals in her credit. Madam Dr. POONAM Verma, please, the mic is yours.
Yeah. So, very good afternoon to all present there. I would today like to present the good practices in midwifery at Mahatma Gandhi Institute of Medical Sciences, Sevagram, Wardha, situated in Maharashtra. Now, first of all, I would like to bring the greetings from Mahatma Gandhi Institute of Medical Sciences, which is the nodal center for midwifery training. Also, this institute believes in community service and has a rural bias. So very proud to be the part of it. Institution is such that none of us practice. We are all there for the rural women rural men and women services. Now, when we talk about midwifery concept, all of us have gone through the literature and all of us know beyond doubts that there have been several advantages of midwifery in which improved labor room experience by the women, reduced cesarean section rates, sharing of the workload, interprofessional collaboration, providing respectful care in true sense, providing a communication which really helps both sides, the clients as well as the providers, and beyond that, promoting physiological birthing. These are the concepts which have come with midwifery. And when we go on to the White Ribbon Alliance Universal Rights, it's extremely clear that we are not supposed to physically abuse the women, which was a constant feature during our past times. We have to give patient-centered care. We have to give dignified care. We have to give care which is confidential. Also, if we look into the various aspects of these universal rights, it's very clear that the women has the right to choose a birthing partner, to choose a position of birth, choose a doctor and hospital. With all that, what comes in our mind is giving her respectful maternity care. This can be only achieved when we have interprofessional collaboration and care by midwives and obstetricians together. Now, if we go into the various journals and see, nth number of articles are there in the very good journals stating that midwifery care definitely changes the scenario of labor room. And when we desire to begin midwifery, we have to have certain components where goal and leadership has to be the prime. And this has already been taken by Government of India and Government of these states because they have realized that midwifery is going to change the scenario. There is technical and non-technical support needed, and there are several organizations, very grateful to them, like UNICEF, JPIGO, White Ribbon Alliance, and so on and so forth, who are helping them. The international midwifery educators are coming and training the people out here in India, and we are going ahead with good midwifery training. Administrative support obviously is needed for this. Teamwork and team effort is the key of this whole process. And what is most important is that we have to follow evidence-based protocol. Now, problem in India is that we are having several guidelines. Government of India has a guideline, state has a guideline, Foxy has a guideline, and so on and so forth. All of us have to ensure that the guidelines should be one, the protocol should be evidence-based, and they should be implemented. And of course, financial support is mandatory. Now, if we look from the stakeholders' perspective for implementation of midwifery, the first and most important question comes is sensitization and awareness of midwifery cadre and its implementation. If you ask most of the obstetricians, they are pretty confused. And I was one of them, but now I am not. The reason being that if we look into ANM, again, it is auxiliary nurse midwifery. We look into GNM, again, there is a word midwifery. So this midwifery word has confused everybody. People are not realizing, or obstetricians are not realizing, that midwifery cadre is for their benefit and not for, snatching their work, which is a common concept of obstetrician as well as nurses. So this has to be, universally informed to all the obstetricians in different states that this cadre is going to help them, and it is not going to, take away their part of the services which is to be given. The solution for this is that there's a booklet which has been created by Government of India, Scope of Midwifery. This has to be disseminated. We need to do a lot of continuous professional education, conferences, workshop, meeting, national, state, district, and facility levels, so as to inform them what exactly this midwifery cadre is. And of course, there's a big role of Nursing Council to look into this aspect of it. Now, this is the scope of practice midwifery educator and nurse practitioner midwife, the whole manual. And this manual has got everything. What is the role of an educator? What is the role of national practitioner? So this, if it is disseminated, probably this is going to make a lot of difference. Coming on to the another problem is infrastructure while implementing midwifery. Midwifery in different institutions. Now, we have a labor room, but this is very simple. If you have place, you can create an MLCU separately. But if you do not have place, you can just modify your labor room. And you can create a MLCU, which is midwifery-led care unit, and your normal labor room. And this is what we have done. Our center is a model center for MCH wing, and this is being replicated all over India. Now, this is very simple that you have a triaging, which is very close to your gate. Then you have a low-risk labor room. You have a high-risk labor room, which is attached to high dependency unit. And then you have maternity OT and ICUs. So this is very clearly mentioned in a very interesting book, which is called MNH Toolkit, where LDR has been described very clearly, and MLCU needs to be simply added there. So this is another issue which midwifery.
Infrastructure.
The next problem was site selection for nodal midwifery training, and I think this role has been done by government. There are 4 or 5 centers which are very known, and they are doing all midwifery training. The next important problem which we faced during our implementation of midwifery was interprofessional collaboration. So there was always a kind of cold war between the resident doctors, the consultants, the nurses and midwives, and by repeated conversation amongst them, by repeated meetings with them, that there is no boundary. These are all united decisions. These are teamwork. We could solve all these problems. And now if you see in MGIMS, everyone is working together without any issue. Also, midwifery, when you talk about the strict supervision, is very much necessary, because the quality training is the crux of midwifery training. The lot of feedbacks which have to come, it should be a loop where you can tell them what are their issues and they can tell you what are their issues. So it should be a feedback loop, and we've been doing a lot of debriefing, which has really worked very well. Also, as we are doing the adult training, you have to understand that it should be a sandwich approach. Do not depreciate somebody continuously. Appreciate, then tell what are the improvements which have to be made, and then tell them that with these improvements, they are going to do very well. So those kind of approaches helped us very well in implementing. And last but not the least, procurement of equipment and consumable. People have a concept that your equipment and consumables are very expensive and things like that. No, not at all. The props are very cheap. The alternate birthing props, the aromatherapy, what is given for non-pharmacological pain, is very cheap. So we can procure this. Only thing is that there is a list of these things which have been given in the scope of practice manual. One has to see that, and you can easily get these consumables and equipments for midwifery-led care unit. Clinical training cannot be right on to the patient, because all of us probably believe in humane approach. So the skills lab is something which government has to help us, and government is actually helping for giving these mannequins, simple mannequins, which will train them how to deliver a baby and what is the new method of delivering the baby, not cutting the cord immediately, keeping the baby on the mother's abdomen, and no episiotomies. So those kind of things can be trained. Once she is trained, then she can come and see the patients. Also, one has to realize that when you are doing this kind of job, some kind of rewards, some kind of opportunities, looking into their career progression, because there's a lot of apprehension in the mind of midwives that they are taking this training, they are spending their 18 months, but what next? These midwives should not be posted back again to their centers as nurses. This is something which government has to look into, that their career should progress. They should have some kind of financial gain. And this we have been doing. Our 5 midwifery educators, we take two of them. They have gone to international level also, presented their work, and they have got the rewards. So I think it's very important that we look into their career progression as well. Future involvement, I would say that finally the system has to integrate, the NMTI has to integrate with SMTI, district hospital, not only public facility, but private facility should have the midwives along with them. And of course, the community involvement is important. So it's extremely important that we have full system integration. Now, what are the challenges in implementation of midwifery, and what did we face? Of course, there was hierarchy. It was very difficult to convince the obstetricians that this cadre is something different. But now with the repeated meetings, repeated, professional education programs, we've come to a consensus that this is a cadre which is between the doctors and the nurses, where they can deliver all low-risk cases. Awareness of program needs to be a little better. Acceptance by medical professionals like nurses and all, again, has to be better. There have to be mutual coordination. One problem, what is a real challenge, is that the people who are coming for training, many of them are from nursing college, and nursing college people are not so exposed as a nurse who's been working in the labor room and delivering the nth number of patients. So that kind of clinical experience training we have to plan in such a way that those who have not had clinical experience that much, they should be posted more for the skill learning and clinical experience. Also, the limitation of each of these midwives have to be made very clear, because over enthusiasm is not good, and that can create an issue and lead to harmful practices. Also, the philosophy of midwifery is a challenge, because people have been, obstetricians have been delivering the babies, and as an obstetrician, I am telling you, many a times you do not let the baby restitute. You in a hurry to take out the baby. But this philosophy is something different, which has to be learned by the obstetricians. Coming on to what are the responses to these challenges. So again, as I told you, repeated meeting, institutional, district, state, etc., making a team, communicating between the team, interprofessional collaboration, resource building, and so on and so forth, which I have already told you, the feedback loops and modification. Now, these challenges can be met in, we are doing art of birthing workshop at different places all over India, and we are seeing how people are changing once we tell them that these are the methods and these are all evidence-based methods. So people are changing. We've done nearly 4 or 5 art of birthing workshop, and we get repeatedly the calls that, okay, today we delivered her in this position. Today we gave her this non-pharmacological method, and things are changing completely. So this is what we need to look into. And as I have already told you, there are multiple benefits of midwifery. What we have encountered is that now we have a much better birth preparedness and complication readiness counseling methods. Women are coming, sitting in groups and learning. Selection of birth companion is by themselves now. Lot of women are using non-pharmacological methods for pain relief. And we are completely doing alternate birthing position every month, nth number of people. We have included hydrolabor also, for which I give credit to the Fernandez Hospital, who's probably the first hospital who's been doing all these things. And Dr. Avita was kind enough to let my postgraduates and me be there and learn a lot of it. And so we completely recognize them for that. And of course, if we look into additional benefits, the work distribution, the work has reduced. There's mutual learning. PGs are going and learning from the midwives. Complications have reduced significantly. No prolonged labor, no obstructed labor, no previous scar rupture. This I can say categorically. And our NICU admissions have significantly reduced. And you will be surprised that now more patients are coming and looking for the midwives. Because in OPD, when there is a low-risk case, we put a symbol there of purple color and send it to midwife. The way they talk, the way they counsel, they are not in hurry. So probably the more women are wanting midwives to see them. So that's really something which is very wonderful. Sharing our experience on RMC, this is our model wing which we have created. These are our LDRs. You can see this is our newborn care area, high dependency unit, intensive care unit, operation theaters, which are very musical, at the same time, very, very efficiently managed, neonatal ICUs, postnatal ward, which are airy, lighted. And this is some skills lab, which has worked very well with us, where we train our undergraduate, postgraduate students and the midwives before they touch any patient. This is our midwifery-led care unit. This is the counseling, and you can see that they are counseling prior to the delivery, everything about alternate birthing and birth companion. So we have trained 30 students from Maharashtra, MP and Bihar. MP and Bihar, they could do much better than Maharashtra. Maharashtra, there was a lot of changing scenarios of the officials. So now we have already, started SMTIs. So look into the changes what we had after midwifery. The cesarean sections reduced, labor complications reduced, and ICU admissions reduced. And if you look into the next slide, you will see that normal deliveries are much better. Caesareans have reduced. Episiotomies are much lesser. Perineal tears have slightly increased, but they are first degree most of the time. This is how we are doing hydrolabor. We have nth number of videos now, which we are presenting while doing the art of birthing workshops. So you can see that we are doing hydrolabor, we are doing chair births, so on and so forth. So any position, whatever patient selects during counseling, we allow them to deliver semi-reclining. Also, we are now passing it on to different institutes. The Pravra Institute, Loni, is doing a lot of deliveries, and Dr. Bangal has started, those videos. He's capturing the videos, and they are really doing very well in alternate birthing. But what I want to say is that midwifery does not mean only alternate birthing position. Midwifery means true respectful maternity care. And if you see, you are the one who are deciding what kind of chair you will make, how comfortable it should be for the women, how do you give her relief during pain, how do you support her. So supportive care. So it includes everything and not just alternate birthing position, which is a common understanding. Now, these three ladies, I really thank them because they are the ones who have actually changed the scenario of labor room. And we recognize them being an international midwifery educator who have taught us what actually respectful maternity care is. So I thank all the partners who have supported us, and we have created truly a model where in the most rural area where the women comes with a half an inch of mud, the way my ayabais are scraping that mud, giving them bath, taking them on the labor table and giving the care which probably a women in corporate hospital will get after paying a lot of money. Thank you very much for your patience here. Thank you.